So we're changing tack completely, and this is a bit of an experiment. We wanted to recreate a virtual MDT. So my eminent colleague, Helen Marr from Newcastle, Piers Patten from King's, and Ross Johnston from Brighton will be running MDT. And actually ahead of today's MDT is Helen Marr. So over to you, Helen.
Thanks for the introduction, Renata. As she said, we wanted to sort of informally talk through some real life cases, a bit like running MDT. We haven't kind of like looked at all the cases together ahead of this session or anything like that. So we did just want to kind of have a discussion amongst ourselves. As Renata said, this is with me and Piers Patten and Ross Johnston, but I'm hoping that while they're still on the call, Nick and Tal and Renata and George will chip in with some comments as we go along as well. And we really wanted to kind of focus on real life cases. They're all real life cases. So we're really talking about what decisions do we make and what do we really do when we're talking about our patients and trying to make decisions in terms of their cases, rather than kind of focusing on trial data or sort of right or wrong answers, as it were. And we've deliberately included some slightly less usual cases, kind of less usual presentations of CLL to kind of cover some of those oddities that come up in the MDT from time to time. The first case, I'm going to hope that Ross will appear.
This is somebody that I've been looking after recently, and I mean, interestingly, having just been talking about the increased risk of infection in CLL patients, even when they're untreated, this is somebody who presented actually to the respiratory department with she'd been followed up by her GP after a respiratory infection, and she had persistent left lower lobe consolidation on her chest X-ray. She was an ex-smoker and had a history of breast cancer quite a number of years ago, and went on under respiratory to have a CT scan which showed some lymph nodes in her neck and her axilla, and nothing particularly concerning in the chest itself apart from the consolidation. She had a normal bronchoscopy, and she had a biopsy from her neck, which was consistent with CLL or SLL, and in fact she had CLL because she had a peripheral blood lymphocytosis measured at 14, but otherwise normal counts. And she came to hematology and didn't see me, but had that terrible label put on her of just being watched. And I think one of the things I wanted to reinforce here, which has probably come up earlier in the course, is that when these people come to clinic, that one of the key things to do is to ask their GP to arrange their vaccinations. So the additional vaccinations that you're eligible for as a CLL patient are much more likely to be effective if they're given as early as possible in the course of the disease, rather than just before somebody needs to be treated. So that's, I think, something that's important to take away.
Okay, but nothing going on here to indicate that she needed treatment at this point?
No treatment indications. She was otherwise pretty well.
Okay.
But she got admitted to hospital again and had more lung things going on. So progressive bilateral pulmonary infiltrates with quite an impressive chest X-ray. And through the chest team, they went on and took a biopsy from her left lower lobe, which perhaps unusually showed infiltration with CLL. There's concerns obviously about her history of carcinoma, but nothing to be seen in these biopsies. And all of a sudden, if she really has got CLL infiltration of her lung parenchyma that's making her unwell, then that could well be an indication to treat this lady. So she went on to have some further imaging. If we just go on to the next slide. Actually, she had quite significant disease burden, both in her chest and really quite bulky disease in her abdomen that you'll see on this, on the PET scan on the left. So she had quite bulky disease in her abdomen. You can see in her neck and her axilla, she had quite a significant nodal burden. So go back to the previous slide. Everyone was happy that she warranted some treatment. She hadn't seen me at this point. She had an unmutated IGVH gene and deletion 13q, and which I think can go with extranodal manifestations of CLL, if I remember correctly, but she was started on acalabrutinib. So
can I just ask you, Ros, with this scan, with all that bulky nodal stuff, did you have any worries about high grade or needing to biopsy anything, or?
Well, she had just had her left chest biopsied. It was quite bulky, but actually it's always difficult on these snapshots from PET scans, but nothing was particularly super hotter than anything else. And as far as I remember, her LDH was okay. There was nothing that we were too concerned about in terms of high grade disease at that point. She was started on some acalabrutinib. So I think another interesting question that comes up is she was coming in and out of hospital with recurrent respiratory infections. So I think it will be interesting to get people's views on what they do with a BTK inhibitor when somebody comes into hospital unwell with infection. Do you, Helen and Piers, do you continue the BTK inhibitor, or do you stop it whilst the patient is unwell and restart again once they're feeling a bit better?
Piers, what are you thinking? And somebody's put a question in the Q&A as well about RSV vaccination.
I think it is interesting about that. I think it depends where in the treatment they are. I mean, if they've been on something for, and you're confident that their CLL is well controlled, I might feel very differently about it. And if it's someone who's just started treatment, let's say with quite aggressive disease, we might see later where you can run into trouble with stopping BTK inhibitors because of things like that. Does it help their immunity? I've become deeply skeptical about that on the basis of the vaccine study we did recently and now published in Lancet Haematology. Does it interfere with things? I think quite possibly. So you might want to see what other medication you're going to get. So I don't think there should be a hard and fast rule. I think in our hospital, and I'd be interested to know what other people do, it's sort of become a default that you would always stop treatment. I'm actually not sure why we do that, and I think it'd be much more much better if we intelligently thought about it.
I rarely do stop it, unless, as you said, somebody. I rarely stop it if somebody comes in just with infection. Piers, just for an educational thing, will you give us 2 or 3 lines the vaccine study that you mentioned, just for
I mean, particularly for patients on. This was for patients on BTKI. It was run out of Birmingham. It was called Improve, and it was looking to see whether interruption of BTK inhibitor in patients where it was deemed to be safe to do so might benefit in seroconversion to COVID antibodies, to COVID vaccinations, and it's seroconversion, just looking at whether they would get antibodies against COVID. And the short answer is it made no difference at all whether you stop treatment or not. And I think it's quite a nice, in a way, negative study in terms of the hypothesis was the other way around, but actually showing that sometimes we overthink these things.
Yeah, and I think in fact with this lady, when I saw her in clinic for the first time, what I was worried about was that she had been in and out so much that actually she hadn't had a decent. I didn't know she wasn't feeling any better because something was wrong, or because she just hadn't had a decent few weeks of BTK inhibitor. So in clinic we agreed that whatever happened for the next sort of 6 to 8 weeks, she would keep going with her BTK inhibitor. I think my experience, which I hope if we just go back, my experience is that patients, that sense of well-being that patients get on BTK inhibitors usually comes quite quickly, that people feel, dramatically better often within a few weeks. And it can often be, one of the first things that they notice about taking their medication. And so when this lady came back in another 6 weeks and she still wasn't feeling any better after continuous BTK inhibition, then my alarm bells were ringing. Let's work out what's going on here. And we repeated her PET scan, which is the next slide. And if you can see on her PET that after 6 weeks, that nodal disease in her tummy has all kind of melted away. And if you look at her neck and her axillae compared to her pre-treatment scan, that again, that has completely melted away as well. So we're left with this area in her right middle lobe that's actually deteriorated, and she's got really some very intense FDG uptake there now. Not that I'm a radiologist, but so, you know, at this point now I am worried about high-grade transformation of her CLL. Have we, you know, it's certainly something that I think we've all seen, where you can put patients sometimes on a BTK inhibitor, and if there is any sort of high-grade disease lurking there, sometimes that can be the trigger that everything else responds and high-grade disease can take off. So I think, you know, the whole question of when you reassess patients on BTK inhibitors in general is quite, we've been trying to generate some definite guidelines, but I think for most patients, rescanning patients on a BTK inhibitor often confirms what you already know. The patient feels better, their counts are doing what you expect them to do, and it's unusual that the scan doesn't just confirm that. But in someone like this, who is not doing what you think they should do, and then I, you know, scanned again really quite quickly to try and work out what was going on. And in fact, when we repeated the biopsy from the right side of her chest, she had lung cancer on that side of uncertain etiology. We still don't know if it's related. I haven't got all the results back to know whether it's related to her prior breast cancer or something completely different. So, you know, this lady had 2 pathologies all along. So I think it's being conscious of that in the CLL patient, where we know that the incidence of all second cancers is higher. And I don't know what your practice is in terms of rescanning people, Piers and Helen.
So I have to say,
I don't think I routinely rescan anyone particularly. I guess I've had a number of patients on trial, so I have a feel, but I think I would just go clinically and on blood counts.
Yeah, I'm going to bring Tal in because he's got his hand up in a second. I would tend to I tend to, on a BTK, I tend to wait till their white count normalizes, and then once their white count's normalized, I sometimes do a scan out of interest to see what's kind of happening to the nodes as well, and to say if we're kind of in a complete hematological and sort of radiological remission. I'm going to bring Tal in because he's got his hand up. Oh, and then Renata. So Tal first. Go for it.
Yeah, Ross, a fantastic case. I just wanted to know about the biopsy that was taken first by the respiratory guys. Was that a good biopsy that was taken, or whether this was just because in my experience, if you biopsy anything, you will find CLL there.
Yeah, I think that's the other lesson from this case. That is absolutely my experience. Whatever infection or nastiness or inflammatory process is happening, there's going to be CLL there. You know, every year there's a few patients that come from the breast clinic who've had CLL identified in the nodes from their axillary clearance that really have a very low burden of disease elsewhere. CLL seems to hang out where other pathology is going on. But I think that actually the left side of the lung where they biopsied before did kind of improve. I suspect that was infection more than malignancy. And I think, you know, we wouldn't normally go and biopsy lots of different areas in lymphoma or CLL. We kind of assume it's all the same process and sort of go ahead. I think the red flags were there with this lady because she just didn't feel any better.
Yeah. Renata.
Yeah, I almost had an identical case, but on VO. So poor chap. And again, it's just exactly what you said. If things don't go smoothly, I think we should just reassess. Don't be afraid of scanning. And yeah, my chap, after just completing obinutuzumab, just complained of had a COVID, which took weeks to clear. Also, we thought. I mean, he did have a COVID as well, and then we did a CT, which showed he had adenocarcinoma and sadly died very, very quickly of lung cancer. So I think, yeah, it's a big lesson. Just, just watch those patients quite closely.
Now look, come on, team. We've got like loads of cases to get through in this MDT. We haven't got all day, Come on, George. Come on, then. What's your point?
Yeah, comment. Don't feel bad about scanning someone. Actually, it's a useful baseline. I think Helen almost felt guilty putting someone through the CT scanner. I know we don't overscan in routine practice, but it's not bad. If someone's been on ACALA for 6 months, the lumps have shrunk, their nodes and all. Putting through the scan can be quite useful. So in 2 years' time, when you're trying to look for a reference point, has something changed?
Yeah.
I know we're not all doing it, but it's something to think about.
Yeah, just I would just throw something out there, because obviously the case is quite nicely very clear CLL picture and then a lung cancer picture following. But it's interested to know what would you do if you had known the patient had lung cancer at the beginning. Because there's quite often we find dual pathology and two cancers, one of which is CLL and the other one, and so is what people approach is to that.
Some careful discussion then, don't you, with the other MDT and the other team in a sort of top trumps, whose malignancy trumps whose.
Usually in CLL you can wait most of the time, and it's with pandemic, there are people who probably I would have treated, and yet with pandemic suddenly I can follow them up for 1 year extra, sometimes 2. So I think, yeah, obviously if somebody has got stage C and hemoglobin down to 70 and very symptomatic, of course you need to treat probably halfway, but I think vast majority of our patients probably could have waited.
I think the other thing about BTK inhibitors in the kind of relapsed refractory setting, I think they're keeping people alive that 20 years ago would have died. They would have died from their CLL, and so people are dying of secondary cancers now. These people with very high risk, horrible CLL are being kept alive by BTK inhibitors and then succumb to other diseases as well, which is sort of a success story in itself, because I think their life has been extended by those drugs. But I think I think often those second cancers seem to be quite aggressive and quite rapidly moving in my experience.
Thanks, Ros. I'm going to whiz on to one of Piers's cases, because I'm just aware time has ticked on so fast. So excuse me as I zoom through to try and get onto one which was a sort of relapsed refractory case, just to make sure that we talk about some relapsed refractory cases. So I'm going to get Piers to come and present this case, if that's okay.
Okay, we'll do this one.
And then we can go backwards to other ones.
Yeah, I mean,
because we've got 900 myeloma cases to discuss at 9 o'clock, you understand.
This case is a little old, but I think the message is still the same. I mean, he was age 60, original diagnosis. He actually had loads of comorbidities and including hypertension, and actually no, that's a slightly different case. He's just got hypertension, but he needs to go on to triple therapy actually. Normal blood count, he gets a new diagnosis of SLL, and at that time we don't need to do anything. We talk about watch and wait there. Next slide was the he gets a number of infections and lymphocytosis, starts to progress. He gets disease profiled, and at that time in 2016 he was young, reasonably fit, had deletion of 11q, no 17p abnormality, so he was given FCR. And then he has a pretty poor response to that, really. Completed in June 2017, but already shortly afterwards he started to progress again, and I think actually has PET scan and things like that, and because it wasn't a slightly raised LDH, but in fact the PET scan wasn't avid, and But widespread lymphadenopathy has a bone marrow study. Again, I don't know if I was specifically looking after him at this point, but that showed Pat with CLL, and he's now developed a 17p deletion. So, Helen, you've put what treatment would the MDM offer? And I guess
I've forgotten how old this patient is.
he's now 61.
Okay.
So he's progressed, hasn't he? So I mean, he's got
Feels
two
like-
options. I know it's 2017, but I guess we could talk about it as though it's today.
Yeah.
But
But he's got horrible disease, hasn't he?
he has got horrible disease.
Not done very well with his previous treatment, and now he's got a packed marrow. He's got this high LDH, which feels worrying, and you've told us he's acquired a 17p deletion. So this all just feels very high risk, and I'm kind of feeling mindful of his age, and whatever we give him, how long is it going to last, and do we need to have our eye on a more sort of long-term treatment solution?
Yeah, I think those are very, very, very good questions, and I can't remember the discussion we would have had at that point. I think.
So what are our treatment options for him at this moment? He's had chemoimmunotherapy, and we're thinking what we're going to give him right now.
So, I mean, for this case, I think with the very rapid progression, he's going to need long-term treatment. And I think along with I would definitely be favouring a continuous treatment. And I mean, he could actually get 2 continuous treatments. And I think one would be a BTK inhibitor and one would be venetoclax monotherapy, actually. My preference I would argue, because I think there's more robust data in this setting, to go for a continuous BTK inhibitor. Probably today I would go for a 2nd generation agent, and in fact, on the basis of some of the data, I might favour zanubrutinib actually for a man like this. Would probably be. I don't know what the MDM would want to say about that.
Well, the MDM would document that you could have whichever option you fancied. So you could have your zanubrutinib or your acalabrutinib, or you could have your fixed duration venetoclax and rituximab. So you've got all your options available to you. So you could have a patient discussion. But I think I would agree with you. I'd probably be favouring zanubrutinib. Renata?
Is there a catch that LDH 1162? It's a bit worrisome.
I'm working on the basis that Piers has done this bone marrow, and it definitely looks like CLL with no high grade.
It's a bit high, isn't it? I guess clinically I mean, I always like to think about clinical picture or something like this. So he's not progressed. It's not like overnight. It is quite fast that he's gone that fast. But so far of all those indications, I guess you could wonder about targeting a large lymph node. I can't remember what. I don't think there's much avidity on the PET, and I don't think there's any particularly high volume. But
so I mean, I think any of us, seeing that LDH would probably want a PET, wouldn't we, rather than just a CT? I would tend to want a PET here just to know, is there something that looks asymmetrical in terms of an especially avid lesion, which is bigger or more avid than other sites, that could be a target for biopsy to kind of particularly think about high-grade transformation?
Yeah, I think I was going to say this case depicts perfectly what we're trying to actually investigate, which is the accelerated CLL, which is probably what maybe this patient has, which is still a CLL, hasn't quite transformed to Richter's, but it's clearly taking up a high proliferative, quite aggressive clinical phenotype. And I agree that the best treatment probably is BTK, and specifically in this patient, I think we've got some data that says that acalabrutinib is has slightly lower rates of hypertension. So maybe that probably will skew me a bit towards acalabrutinib, although that's non-randomized data. But
I agree. He's looking at it. He's on 3 antihypertensives, so you might worry about the hypertension.
Yeah.
I guess might want it monitored.
A perfect example of how there's no right or wrong answer in terms of the MDT, and how there could be, there's definitely different treatment options even within the BTKI options. Tal, you wanted to make a comment?
Yeah, I just wanted to ask a couple of things really. If we've got any features on the flow cytometry to suggest that it's more atypical CLL phenotype. And the second thing really is do we get a Chi-67 on this on the sample? And the third thing is when the LDH is that high and with anemia, whether we're seeing some hemolysis there as well. I think we should try to exclude hemolysis because we know that some of the fludarabine treated patients can have quite aggressive hemolysis as well.
These are all good points, and they're really classic MDM because, of course, when you bring them along, you haven't thought of any of these things. Smart personality, always crazy. You have to think quickly on your feet. So the answer is, I don't think we would have. So then, I guess the aspirate would have been re-immunophenotyped. I don't have that data here, but if I hadn't done a bone marrow, I wouldn't necessarily re-phenotype the blood, although my lab likes me to do that in terms of getting a lymphocyte count number for the genomic tests. My recollection is nothing atypical on this man's immunophenotype. Hemolysis, yes, would have clearly thought about that, but there wasn't, but it's a good point. And your final was Chi-67. I'm going to say no suggestion of high-grade transformation means it wasn't that high.
And we've got some questions in the chat as well. I'm going to ask the second one first, which was, is there splenomegaly? And if so, would it make a difference to how you treated?
No, I don't think it would make any difference to what I'm thinking about doing. It might account for not so much the LDH, but it might account for lower hemoglobin.
In terms of hypersplenism, and also answering the question about hemolysis you'd have thought of as well. That would...
Yeah.
And just out of interest, so I mean, we've talked about BTKIs, but one of the questions that's come into the chat is: does anyone still prescribe idelalisib and rituximab second line? Any scenarios where it would still be considered? What would you say to that, Piers?
If he'd been 17p, probably wet presentation, he might well have been a candidate for idelalisib R at first line, because I remember that was funded, whereas ibrutinib wasn't. The answer is no. I think is the short answer to that. But the person who's asked the question has quite rightly identified that it is still available.
Absolutely.
Yeah. I think the latest iteration of the guidelines will definitely not recommend. I think we would reserve idelalisib for failure of BTK inhibitor and venetoclax-based therapy.
Yeah. Yeah. So we've got a patient here we know has got nasty disease, but we have looked and don't think there's high-grade transformation. Has acquired a 17p deletion and is in his early 60s. And you've talked about probably wanting to favour continuous BTKI, and currently you might think of a second generation BTKI. This was back in 2017, so I believe you treated this patient with ibrutinib.
Correct. So he got ibrutinib because that was what was available. I think idelalisib would have been available, and I can't remember exactly when venetoclax monotherapy became available actually. But that's all historic. But anyway, we went for ibrutinib, which would have been my choice. Data on ven mono is much less, I think. And I think the features which I've written there are because everyone was very worried. I think our understanding of atrial fibrillation with ibrutinib was becoming much more clear at that point. So we were worried about that kind of thing. Less interestingly, we weren't very worried about hypertension as a signal, probably even in 2018, whereas I think today we would all be looking at that. And he got neutropenia and got some GCSF. They respond quite nicely. So he starts to progress. And now we've changed our methodology. We've stopped doing FISH and we now do SNP karyotyping. And that gives us a lot more information. And it becomes quite apparent that this man has got a complex karyotype. He's also got an amplification of MYC, which we see a reasonable amount of. He's got a TP53 mutation. We confirm he's not very surprisingly unmutated. And he's relatively young, relapsing again. So
he's progressing after a year of ibrutinib.
Yeah.
And so he's still in his early 60s.
Thinking about, we did implement a mud search for him, 9 out of 10.
And just so noticing here with your P53 mutation detected, so presumably this was on some sort of NGS as opposed to previously you've just done FISH and found your deletions.
That's right. So I think
being
this shows this is a historic case, isn't it? So it shows how things have changed. And again, you might well bring me to the MDM all these different techniques. I have a feeling it wasn't an NGS test in 2008. It was a single gene test. We didn't have a lymphoid gene panel in 2018. Today, he would have got a lymphoid gene panel at our institution. And just to say, I would, although we did the IGHV there, I think this was, it hadn't been done before, but every line of therapy, I would repeat the genomic.
You've done a donor search, you've kind of got that allogeneic transplant in the back of your mind, but in terms of your next line of treatment,
I think a discussion was had, and I mean, he's failed BTKI, so I think everyone would have progressed him onto venetoclax, try and regain disease control. I don't think I would have tried to do anything else at that point. So I guess the question now for the MDM, that's just his kinetics, just put those up. What do you do now if we put it forward to 2024?
So we're sitting in our MDT thinking about this. What do you think, Ros? What would be your thoughts about this patient?
Well, I think it's interesting because even though, you know, things have changed an awful lot since 2018, actually, the main difference would be he probably wouldn't have had FCR 2 years previously. But if we had someone who progressed after a year on a BTK inhibitor at a young age, you're still picking out an incredibly high risk population who is presenting themselves as someone who is going to exhaust the options available to us when we open the CLL medicine cabinet that we have within their natural lifespan. So, you know, for the majority of patients who present in their 70s now, that's not the case. The drugs that we have are likely to see them through their natural life expectancy. But this is somebody whose CLL is going to be a very different proposition. And I think that although we do have some more drugs than we did in 2018, I think that I would still be thinking about, I think we always think about allogeneic transplant, and thankfully we rarely have to do them. But this is somebody where you would still be strongly considering the option of an allogeneic transplant. I don't know if anyone else feels differently.
No, I would definitely agree. I think, I guess one of the questions is timing, isn't it? In terms of when do you do it? If you started the patient on their venetoclax, if you're getting a good response, when do you think about the transplant? I was going to ask Tal though as well, if this man said absolutely no chance, I don't want to have a transplant, what a ridiculous idea, what could be some of his clinical trial options? What other kind of options could he have for some kind of disease control at this point, having gone through his chemo and his BTKI and his venetoclax, assuming he's going to progress at some point in the future on the venetoclax?
Helen, in terms of, I agree with Ross that these are more and more patients where I'm doing allogeneic transplant in these patients, because one of the things is that we now got data on non-covalent BTK inhibitors. As should this patient go on to venetoclax with 17p deleted CLL, we know that the median PFS is around 24 months for these patients, whether you use venetoclax monotherapy or not really. So in these patients, I do tend to monitor the MRD, and if these patients are still MRD positive at the end of the year, I strongly ask them to consider a transplant after they have been on a year of venetoclax monotherapy or venetoclax rituximab, because you want to salvage them when the disease bulk is low. I think the problem we find ourselves is that we think about it for a long time before they miss the boat, really, to be honest. So that's an important point to consider. But should the patient, and I've had patients in this situation who've said, no, I'm just very happy with venetoclax monotherapy. And in those cases, non-covalent BTK inhibitor, PERTO is the right drug, but you're expecting a median PFS between 13 months to 18 months. So again, when you get them into deep remission, you need to ask the same question again. And then we've got BTK degraders, and we've got a few other phase 1 studies with MALT1 inhibitor or CDK9 inhibitors. But we're talking about just on chance what to do with these patients. So I think in these patients, I agree with Ross that actually we need to strategize pretty quickly what we want to achieve, and kind of start the discussion a bit earlier rather than later.
I was going to say I probably concur with the indication of allotransplant, although this particular case patient, it is a bit tricky because having only a 9 out of 10 donor brings the TRM up very, very much up. So you're looking at a patient that is going to have, was very likely to have GVHD and have significant impact on his quality of life. So something you have to consider very carefully. So just to, as you know, as the educational point is, when you talk about allogeneic transplant in a CLL patient, I think the donor counts very much into the discussion of what, because the suitability and type of donor, if it's a 9 out of 10, a 10 out of 10, or a 12 out of 12 matched donor, will have or a sibling will have a tremendous impact on the TRM of the transplant. And just to say that I've referred, on this year, I've already referred a couple of patients who've had similar treatment pathways as this gentleman has, unfortunately. And I've been managed, and I've had no choice in a couple of occasions to bridge these two patients to allograft with Campath, the old school way. And it's still early days, but yeah, so the Campath's still there. It works very well. And it's something to consider when you're going down the route of this allograft.
Ros and Piers as well. Somebody's put a question in the chat about a CLL patient with bone marrow failure. Are you still happy using Septrin or cotrimoxazole as prophylaxis, or would you use something else? So I guess kind of just thinking about cytopenias and is Septrin potentially making cytopenias worse? I would tend to still use Septrin as prophylaxis alongside a BTKI. Would you all do the same?
Yeah, I would. And I might not get too, I mean, if they can't tolerate it, I might just then drop it and not get too fussed about giving anything. I still think the rate of PCP, I know that there was this alert out and everything else, but the rates are incredibly low. So I think if it's an intolerance issue or whatever, you might be able to just monitor them very carefully.
And the myelosuppressive dose of cotrimoxazole is the one that traditionally is used at therapeutic level for.
No, I agree. So I think I would use it, but
prophylactic dose is very small.
I would use it, but I think if the patient couldn't tolerate it for other reasons as well, but I would use it.
Okay, I'm going to whiz backwards to one of your earlier cases, Piers, because I think this is just an unusual one, and just to highlight that it can be an issue in CLL.
So again, this is a story which came to me actually to clinic, and I guess we took to the MDM. 59-year-old male, hypercholesterolemia, been stage A, diagnosed some years before, mutated IGHV. It seems to have got the full molecular workup actually, and went on a monitor and
manage
and monitor strategy. I'm not sure. It's got a mouthful for some reason. Here we go. He's got lots of problems with infections. So interesting. After 8 years, so fine actually, but I think then has one of those years where he just kept getting infection after infection, including COVID. And I think patients are still being referred to the hubs for consideration of anti-COVID treatment. It's today, recurrent HSV. He's got hypergammaglobulinemia. He gets put on as prophylactic azithromycin, and I think that's because we were hoping to get him to support that with IVIG. So that's a whole massive discussion. And then he has this quite a long history from February 2024, getting headaches. He goes to the ED in Southampton. They do a CT head. It's very difficult to get through an ED without a CT's head, I find. That shows a middle ear infection. He gets migraine in March. he is reviewed by a neurologist at his local hospital. The Queen Elizabeth is in Woolwich, and he has a normal MRI at that time. And then he gets some visual disturbance and ends up being referred to the ophthalmologist. I think he probably went to Moorfields for that.
I don't know about you, but my immediate instinct here is this has nothing to do with CLL, surely. All of this head
Yeah,
business.
I think that's absolutely right. I think someone got, yeah. And they find he's got stage 5 papilledema. And really unable to complete all those investigations, and his symptoms get worse. I seem to remember talking to him, it was the headache was the worst features, but really quite a lot of symptoms there actually. I think he keeps bouncing in and out, and no one's really sure what's going on. His CLL's not changed much. He has got a stable lymphocyte count, but now developed a mild anemia, and he has, I think on questioning, got some B-type symptoms, night sweats and weight loss. I think I see him in clinic, and I send him, and he's being worked up at the same time by the neurologist. And now he comes to my clinic and happens to be going to have these investigations, and I tell them to make absolutely damn sure that they fully investigate the CSF, including immunophenotyping, if there is any evidence for lymphocytosis. And that's what happens. So this was, he had a high opening pressure and a florid lymphocytosis in his CSF, and that is all CLL on immunophenotyping. And it's cultured and nothing comes back, and I think it's sent for every single
fancy virus
test under the sun for viruses, and nothing comes back.
To me, it's a little bit like that. If you biopsy a bit of somebody with CLL, you'll find some CLL there.
Yeah.
But that's an awful lot of CLL in his CSF, so it's feeling quite worrying. But my initial thought in a patient with CLL presenting with headache and eye symptoms would be, surely this has nothing to do with the CLL. We need to find another cause. We need the ophthalmologist and we need the neurologist. This is something else. But that level of CLL in the CSF is worrying. George?
Yeah, so as the years pass, we're always getting pressure from our colleagues of different specialties, of course, because CLL patients present everywhere and they end up with symptoms, and CLL is found. I just will reflect on a patient of mine who was losing his colour vision, and everything just was going a bit wrong, and he ended up in Moorfields. And of course he had CLL, and he'd been treated previously. His white count was about 20, but he had a degree of optic disc swelling. And everyone, your colleagues will tell you it's CLL, whether they're renal, ophthalmology, respiratory, and they think we're getting in the way. And so this was one of these, right, okay, I'm going to give him my ibrutinib because I can, and it won't make any difference. Anyway, this guy's vision all improved. And there's a lot of backtracking. But thankfully, I'd been 15 years in the game by that stage, I realised to always cover my bases. So you always cover yourself. A little unlikely, but all things are possible in medicine, so you know. So I would have given in by this point on this guy. I wouldn't have given him Gala because of the headaches. In today's day and age, I'd just give him some zanubrutinib. We've all had the odd strange lymphoplasmacytic with weird sort of Bing-Neely stuff improving dramatically with zanubrutinib. It penetrates the brain. I would just give it, and I wouldn't get myself too stressed about it, and just see what happened. I think that's what I'd do.
I didn't get too stressed, George.
But you never get stressed about
Really?
anything, Dr. Patten. Late night DJ boy.
Interestingly, doesn't look like doesn't look like he had much on his CT here. So his
No, he
CT
didn't.
wasn't giving you any guidance in terms of dramatic takeoff of the CLL or anything like that.
So we did give him some steroids. I think I don't know whether you need to do that or not actually, but and then we started ACAL as it happens. And I'm assuming George is choosing zanubrutinib because of the license in Waldenstrom's rather than or do you think it's actually more efficacious for CNS?
Oh no! I was just thinking of headaches. Just can't be bad.
Yeah.
Do we know who? I mean, obviously we know that ibrutinib crosses blood-brain barrier. I mean, do we know which of BTK is best at crossing blood-brain barrier?
I can give an opinion to that. So there is the PRISM study is about to read out, and there's very good data about CNS penetration. It's with PK CNS PK so studies in the CSF that will show that zanubrutinib does penetrate very well into the blood-brain barrier. So I don't know if the acalabrutinib does the same. It may be, but I think it's fair to say that the strongest evidence will be for Zanu in these situations. The other thing to say here is that bendamustine does penetrate the blood-brain barrier very well, so it's another thing you could use. In a situation such as this, if you don't think that the patient is made suitable for any BTK inhibitors for whatever reason.
What about venetoclax? Do we know if venetoclax penetrates the blood-brain barrier? Is that an option in these CNS?
I think there are case reports of venetoclax working in the CNS.
But we all have a bit of a feeling about the BTKIs in
No,
this.
I've got quite. I mean, certainly with the ibrutinib, I have quite a few cases, and
I've got another lady on acalabrutinib as well, who's very similar and has responded. There was no zanubrutinib. Acalabrutinib was the only thing she was eligible for at that time, and she's done very well on that.
I think the important take-home message of this case for me is sort of an educational setting being that the CNS CLL is a thing and it's uncommon. You don't see many cases of it, but while we know that CLL turns up in all bits of people who've got CLL, sometimes it will be the cause of the problem, and it does appear in the CNS. It's not, it's obviously not just the LPLs or the high-grade lymphomas that appear in the CNS. So we do need to remember CLL. The eyes must be a thing, because I've got exactly the same case as well, a person with dreadful eye symptoms all getting better on acalabrutinib.
Interestingly, I had an older case who presented with visual loss, and we gave bendamustine because and it didn't make any difference. I think we left it too late. So I think it's worth. Yeah, I think once you've excluded all the sort of worrying things, and I think the other thing is to get on with treatment. Also, I don't think it equals high-grade transformation. So just because it's in an old place, I think it can still CLL can be very CNS tropic, and I've had patients who've relapsed and this, I'm sure we all have, patient who originally presented CNS 20 years later, goes back to the CNS again. So there must be some CNS tropic CLLs around.
I'm aware of that we're coming up to the end of our hour in terms of time. I'm going to come to Tal because he's got his hand up, but just a couple of questions in the Q&A first that I'm going to ask you, Piers. So first of all, specifically about this case, was cryptococcal meningitis considered, which I'm assuming was ruled out with the LP and all these sort of
correct. It was considered, and I think the stains and everything were done, but yeah.
And also this comment about the new FDA prescribing information warning of additional cardiac toxicity with acalabrutinib. Does that, in general terms, in CLL, your choice of zanubrutinib or acalabrutinib?
I think Renata just said, yeah, it has appeared. Then I think the incidence is still incredibly low. I don't think it would significantly influence my choice.
Affect your choices.
I think it's a function of time in the market. So if we give it a few years, then some warning will appear for Zanu as well. I think it's a class event.
Yeah. Zanubrutinib has the cleanest sheet, but has also been given to the fewest patients. So
yeah,
we're not seeing this in clinical practice as being a worrying clinical sort of signal. Tal, you've got your hand up, and then we'll bring things to a close.
Yeah, just a quick question again about the so in my opinion, sometimes these CNS ones have got a very weird phenotype as well, and they usually have trisomy 12 and also have got a very strong CD20 or CD200 expression. Lastly, did we repeat the CSF after, say, 6 months of ACALA? Was there an improvement there in the CSF as well?
Yeah, good question. And the answer is I have not documented there a repeat CSF. I think the clinical improvement has been so phenomenal and striking, and everything else that the answer is we have not repeated it. And again, that's on clinical criteria. And again, you could argue whether you should or shouldn't. I mean, I'm not quite sure how we would change things on the basis of it. So I guess from a managerial point of view, I'm not sure it makes an enormous amount of difference.
Interest, isn't it?
Yeah.
I'm going to wrap things up there and ask Renata as our chair to return. But I just note that clearly this is why all of our MDTs overrun, because we had 7 cases to discuss and we got through 3. But hopefully we looked at a treatment naive case and a relapsed refractory case, and then an interesting case just highlighting that CNS CLL is a thing. So hopefully that was of some kind of educational value and interest. So thank you very much, and thank you for your questions as well.
So this is the end of our 3 Mondays marathon of the basic CLL. Tell us if you like it, if you want us to do it again, and how different, what topics you want to cover. But for this year, we've done it. And so thank you for my co-chair, George Follows. Thank you to CLL Support Association and to all speakers for last 3 Mondays.